supposed to play. You claim not to deceive me. Now you won't leave me. Ain't no love, ain't no love, ain't no love lost. Ain't no love lost. I guess you've now become some Miss Casanova. And with a little luck, you make it over. You may not know that with another love's hard to find. And what's been played on me can be played on you in time. Who am I to say how women are supposed to play? You claim not to deceive me.
You don't remind me. I didn't get to listen until the night before, 11 o'clock.
Oh, you made it. Dude, you said
I
get worried.
You like to keep us in suspense, you know, you're very good. Just catch your breath.
Have some water.
Where are you running from?
Good evening, everyone. Welcome. We're in one of the big rooms for this session, so if you want to move down, you're welcome. This isn't a classroom where I call on the people in the front row. I welcome everyone to the Rapporteur session that has become famous at the closing of the union conference. But before we move into that, I want to bring you back to one of the traditions of the union. And throughout the week, we've been celebrating and recognizing individuals who've made an outstanding contribution to TB control and lung health by presenting a number of the union awards spread out through the plenary sessions. It gives me great pleasure now to introduce the Princess Chichibu Memorial TB Global Award. And to do this, I actually want to welcome Professor Shoji Kudo, the chairman of the board of directors of the Japanese Anti-Tuberculosis Association, to tell us about the award and to present the winner. Professor.
Ladies and gentlemen, it is my honor and pleasure to be here today at this ceremony to give the Princess Chichibu Memorial TB Global Award. On behalf of Her Imperial Highness, Princess Akishino, Patroness of Japan Anti-Tuberculosis Association, JATA. This award has been given every year since 1998 by Japan Anti-Tuberculosis Association in collaboration with the Union at the World Conference on Lung Health in recognition of the distinguished achievement to international anti-tuberculosis activities. Please allow me to briefly introduce the background of this award. Her Imperial Highness Princess Chichibu has been the patroness of JATA from its foundation in 1939. Shortly after, she had started to serve as patroness. Her husband, Prince Chichibu, a brother of the previous emperor, got TB and passed away after more than 10 years struggling. Upon this sad experience, Princess Chichibu devoted herself throughout her life to the prevention of TB. This award was initiated based on her will to make the world free from TB. The winner of this award for 2016 is Professor Asmail Soni, a Director Epidemiology Laboratory for Research and Public Health, Khartoum, Sudan. She is medical epidemiologist and an expert for the public health program with a special experience in TB management and health system strengthening. Professor Soni has served as the Director of National TB Program of Sudan and the former President of the Union. She has contributed to the progress of the disease control and health system development in developing countries with her outstanding leadership based on her scientific knowledge and administrative capacity with confidence and enthusiasm more than 20 years. I, on behalf of JATA and the Union, would like to invite Professor Soni to receive the award for her outstanding contribution to global TB control and prevention. Professor Soni, would you please come forward to accept this award? Congratulations.
I am privileged to receive this important award, and it will go to Farouk Kadouda Center for Development and Democracy to study the catastrophic event of TB. Thank you.
Now we're going to do the Rapporteur session with the wonderful team, the CCSA. As I mentioned in the opening, there were 1,780 abstracts submitted. 160 oral abstracts were presented in 25 sessions, and you can see the rest. There were quite a few poster presentations and some very successful e-poster presentations this year. I want to introduce an amazing group of people that I have worked with in the past year to not only review abstracts and coordinate, but they have been running around during this conference to ensure that the best of the best abstracts are being presented here today. We have the 4 chairs of our sections and the 4 program secretaries of our sections and 3 program secretaries of the subsections. They're all sitting here on stage, except for Zolani Barnes. Oh, he did get put up there, is taking the place of Eveline Kibuchi, who had to leave. A big thank you to session chairs. There was an enormous response this year with responding to the Rapporteur query to have you identify the best abstracts in each session. And if it weren't for you, we would not be able to put this session on here. I got the conference statistics this morning. I think it's quite interesting. There were 3,069 participants from 123 countries here this week that have registered for the conference. You can see the breakdown by region. It would be a very ugly pie chart if I tried to put 123 slices there. The Asia Pacific had 12 countries represented, so you can see in the parentheses next to the region the number of countries represented. Africa had the largest number of countries represented with 39, and they made up 20% of the conference delegates, and Europe had the largest representation with 36%. The UK alone had the largest registrations. Now, A to Z in 50 minutes, although we're going to have to make it A to Z in 47 minutes. I would like to call up the first person, Andrew Steenhoff, to cover adult and child lung health.
Great, good evening. So we're going to start with 5 minutes on the best of the best in adult and child lung health from this conference, taking from oral sessions, abstracts, presented, posters, etc. So from an adult lung health standpoint, lots of exciting things presented, and these were three key ones. There was a lung health awareness program presented from Uganda, where the group noticed that 16% of the adult population had COPD. And the healthcare workers expressed to the group and said, we need educational materials. Specifically, we need to learn how to try and help people to prevent chronic lung disease and to detect it at an early stage. And so this group, Jones et al., developed an educational package with patients and healthcare workers. And please go to this link for the educational material, which is readily available for all of us. Moving on, Chauhan spoke about a community-based screening for COPD in southern India. This group used the IPAG questionnaire, which is an easy-to-administer tool, they told us, to screen for COPD. And they found COPD in 33% of just over 1,000 people screened. And finally, for this slide, Balakrishnan and team used PAL, a practical approach to lung health in Kerala, India. What is PAL? Well, it's a patient-centered approach to improve the diagnosis and treatment of respiratory diseases in primary care settings. And their results were compelling. They did a pre-post analysis of looking at medication use, and just one of the groups was antibiotic use in this age of emerging resistance. And they showed an impressive reduction in various antibiotic use from between 18 to 46%. So it looked really encouraging. In this year, the student oral abstract session, Asfor and colleagues presented on TB in prisons in Ethiopia. They did active case finding in a large prison in Hawassa and screened inmates with a cough for more than 2 weeks. 2 sputum samples were sent, and you can see the testing that was done. And they reported that 19% of people screened had a positive cough. 5 were already on TB treatment. 2% were AFB positive, and 8% were gene expert positive. Really, the most compelling part of this study is the next point, that the point prevalence of pulmonary tuberculosis was almost 2,000 per 100,000 persons in this population. And this rate of TB is 16-fold higher than in the general population. And so they really drove home the important point that active case finding needs to continue and ramp up in high-risk populations. Childhood tuberculosis, again, lots of inciting abstracts presented. The first one from China spoke about open the windows in schools. This group did a public health prevention to enhance air exchanges and ventilation in schools just by encouraging or instituting a program to make sure windows were open in Shanghai. And they documented, again, a pre-post annual average number of TB outbreaks in schools that dropped from 1 to 0.25 per year. And the only one that happened subsequently was in a private school that wasn't listening to the public health authorities to the same degree. Sanai then went on to talk from Afghanistan about intensified screening for child TB. Diagnosing TB in children is not easy. This group introduced a package which consisted of staff training, diagnostic equipment, and a small incentive of $2. And they assessed their impact by a pre-post National TB Program notification assessment. Before, there were 302 pediatric TB cases detected per year, and you can see the results there. In the first year, they had a 288% increase in pediatric TB notifications, and in the second, it almost was a 400% increase in notifications. Incredible results. The third project mentioned here is from Mweni and colleagues in Nairobi, Kenya, again looking at case detection in pediatrics, in this setting in informal schools and informal settlements where they screened just over 11,000 children. They used a simplified pediatric TB diagnostic tool and diagnosed 4% of children with clinical tuberculosis. And this group made the important point that we need better tools to make a clinical as compared to a microbiologic diagnosis in children with tuberculosis. Patel et al. Drew our attention to the whole issue of childhood tuberculosis and malnutrition. In a collaboration with UNICEF, Patel looked at this question of, is routine TB HIV screening being recommended around the world for all malnourished children in high-burden countries? And they assessed country malnutrition guidelines to see if in the guidelines this was appropriately dealt with. And they looked at 17 high TB burden countries. They found that in 76% it was documented that TB was a potential cause for failure to respond to treatment of acute malnutrition. And obviously by default, a quarter of countries didn't even mention it. They also found that routine screening for TB is recommended among acutely malnourished children in around only 41%. So room for improvement there. On the same theme, Adler and colleagues working in KwaZulu-Natal in South Africa looked at how common TB is in children with severe acute malnutrition. And they found that of 82 children admitted, 26%, so a quarter of them, were actually diagnosed with tuberculosis. And you can see the breakdown there of those who were microbiologically confirmed versus clinically. And finally, Dupré and colleagues from Stellenbosch, Cape Town, South Africa, explored the impact of childhood TB, or the impact of smoking in the home on childhood tuberculosis. You can see the aim there to investigate the association between household environmental tobacco smoke and prevalent MTB infection. It was a prospective community-based household contact tracing study, and this was a secondary analysis. Startlingly, they found the odds of TB infection was 3 times higher in child TB contacts exposed to household smoke, and they adjusted for the factors that you can see there. They also found a dose-response relationship with the odds of MTB infection increasing 1.6 times for every additional 2 household smokers reported. I'm going to hand over to bacteriology. Thank you.
Good afternoon. I'm happy to present the results of our subsection. Our subsection is divided into 3 different tracks, which represents the interest of the members of our group. The first track is the basic science, immunology and vaccines. The second, TB diagnostics, including drug resistance and determinants. And the third, the TB laboratory service implementation. And I'm going to give some of the highlights that were given of each of the tracts. So the first one, the basic science, immunology and vaccines. And we're particularly interested in the subclinical active phase, how to test people, how to detect and how to know that indeed from the infection phase the people are going to develop active TB. And there was one poster that had identified that diabetic patients had elevated levels of a certain immunoglobulin called SECAM1, because we do know that comorbidities increase the risk of developing disease. And they say this immunoglobulin might be used as a predictor for the development of tuberculosis in those patients, and then can be used as a biomarker for that. Many of them wish to see that happening, to have a good biomarker for that phase. The other area of interest is the area of testing the drugs. Are they working? But it is difficult. You have to test them in vitro, and there is a study done that used mathematical modeling to make this testing in vitro easier, and that also would have great consequences. Many studies are done in animals, and also in this way they can develop new knowledge about all kinds of issues. And this study was showing that when you are vaccinated with BCG, the drugs you are given are more effective, are enhancing the killing of the tuberculosis. It's not yet done in humans, but for leprosy patients it is known that prophylaxis with rifampicin in those who are vaccinated with BCG gives a much more stronger protection than those who are not vaccinated. So this is also an area of huge potential interest. Then we had, of course, many oral abstracts. I'm going to group them. They were about improving the test in itself. They are about improving service delivery. And they are about improving access to samples, tests, and results through all kinds of means. Often those solutions are local, context-specific, and needs to be done to be adapted to every situation. I'm highlighting one of the presentations, and this shows that even an old method can be used in a very modern way, and this is a whole smear screening system automated, that 2 minutes in scanning and slide will give a good result, which is comparable to the normal traditional microscopy. So in high burden settings, this might be a future, who knows? Then, of course, GeneXpert. We had lots of attention, and GeneXpert testing was here done in South Sudan, increasing the accessibility for primary testing. But then also, we know that we cannot use GeneXpert for monitoring treatment. And this presentation said, well, maybe we can if we use the cycle thresholds for positive test recorded in Expert as a kind of proxy for the bacterial load. And that also will open new ways to monitor treatment better than we can do now. I'm almost to the end. This is the TB diagnostics, the drug-resistant track. And then we had oh yeah, that's not so good news. The failure of the country drug susceptibility testing system. It's not easy. We do have the means, but again and again we show that the implementation really is difficult. And not only that the implementation is difficult, but we still also have basic questions. Are the ways we develop our knowledge, are they appropriate or not? And even we can improve those. And saying this person, author, important to get an accurate picture of the true extent to which novel regimens kill bacilli and could speed up drug development. This is my last slide. The interest. This is a Beijing string, very known in the eastern part of the world, and associated with very strong resistance. And the authors here, they say, it is really necessary that we quickly, and apologies for my, you can read it, spelling mistakes. It's really necessary that we identify those strains quickly and act upon it, because indeed it is so crucial for identification of drug resistance and curtailing it. And then, of course, a very new, promising, exciting revolution for all of us, and that is the whole genome sequencing. And we will not know what it will bring us, but we do know that it will bring us lots of new knowledge, which we hopefully can apply in the future to even improve the services and in the control of disease. And my sincere apologies for those I have not represented in this 5 minutes talk. Thank you very much.
It's all on you. Sorry, she.
Good afternoon. So as Stacey has mentioned, I'm here on behalf of Evelyn. So we're going to be looking at civil society as well as community common. So the first slide that, or presentation that she took was one that was looking at TB patients that were used and also looked at the results over a period of 28 months in South Kivu in DRC. So the method they use, these guys, is that they took patients that were trained to perform door-to-door screening, and these guys were identifying patients with cough lasting for more than 15 days, and then they refer them for investigation. So in terms of the results here is that about 330 ex-TB patients reported screened activities each month, and these guys were able to screen 683 individuals, among of them 10% presented with a cough for more than that 15 days that was mentioned. So 61% of these were tested, and 8.3 were diagnosed with a smear-positive pulmonary TB. So over 10% of South Kivu population was screened for TB, and this figure is about six-fold higher than that is reported by National TB Program when performing passive case finding. The second presentation that came from civil society looked at measuring community contribution to TB program by using simple recording and reporting system or forms, and the method that was used in 12 districts in Indonesia in 2015. And this was done by Indonesian Association Against TB. So the method that they use again is that they took these forms, these RR forms, which is recording and reporting for TB cadres that were developed. And then out of this, 478 community volunteers were trained on these tools. The results that they found was that 6,970 presumptive TB patients were found and referred to health centers. 819 were diagnosed with TB and they were treated. 216 of these, they were cured this far. So the conclusion from this presentation is that TB programs should standardize the forms, the recording and reporting forms for civil society organizations, so a civil society can be able to quantify their contribution to TB programs and TB control. So there was a session on that was relating to stigma, and here there were guys from South Africa, and the method it's a campaign that they use. It's an anti-stigma campaign that is that was conceived by TB survivors and activists in South Africa to reduce TB stigma, as I said, by engaging the public through sharing personal stories, education, and social mobilization. So the campaign, about 35,000 people who wore masks, and these masks had messages saying unmask stigma, and this was done in public, and these pictures were then posted on social media, reaching about 52,000 people online. So the campaign received support in 17 countries and drew attention of key stakeholders, including parliamentarians. You might have seen some of their work in the community common, where they were weaving different stakeholders. The conclusion here is that from the response of societies, they are ready to acknowledge the harmful effect of stigma and are willing to take part. So this gentleman, you might have seen him outside. So part of the community common activities was that the guys managed to have a truck that was looking at intensifying case finding. So this gentleman works as a coordinator in this truck, and he was diagnosed in this truck. So as I said, so these are organized by local community nurses, and this initiative encourages homeless people to come for a meal. And I think the local calls it scouse, which is a beef stew, carrot and potatoes, and it's delicious. I tried it the other day. So these guys were tested for TB, and then they treated on the truck. The good news from this, if I may add, is that from their presence at this conference, they were identified and they managed to get a sponsorship, and that they will be sponsored, I think, £9,000 a year for the next 5 years. Thank you. So the union delivers. If you were in Cape Town, you would have seen Kick TB last year. So we tried to replicate that in Liverpool. And of course, Liverpool being a soccer city, so you might have seen the soccer pitch outside. And this is used again as the hook to get the homeless guys to be part of that. So they use football to create awareness on lung health, Kick TB, and improve lung health. So this is hosted by the Liverpool Homeless Football Club. The session demonstrated a unique approach to sensitize community affected by TB and HIV and other lung health disease through soccer. Oh, and then next up is HIV. Thank you very much.
Great, thank you. So this is HIV, so we'll start with IPT. And this is a novel study by Alison Ryan and colleagues who modeled the epidemiological impact of providing universal and continuous IPT to South African adolescents. And they chose this group because they have a high prevalence of latent TB infection and as of yet lowish HIV prevalence, and are reasonably accessible given that they are in the school system. And the impact of this modeling, as you can see, was modeled over 20 years. And if we reached a 50% coverage of IPT in this age group, the model suggests that we could contribute from 5 to 35% reduction in TB incident rates in the general population, or even as high as 40% if we reached 90% coverage in this group. And so these data suggest this may be a useful target group for IPT, where the possible harms may be minimized and the public health benefits maximized. There are persistent questions on the infectiousness of HIV co-infected TB patients, and this obviously has very important implications for TB control. So this was a study in Kampala that assessed over 2,000 household contacts of all ages of HIV positive and HIV negative index cases. The contacts were assessed for latent TB infection via TST, and also were assessed for active TB disease. And they followed the patients up for the contacts up for 2 years and assessed regularly for incidence TB. HIV positive index cases were associated with less transmission, as you can see here, to household contacts. And it appears that this lower transmission rate is driven by lower transmission from HIV positive cases who are smear negative or who are have non-cavitatory disease compared to HIV negative cases with the same disease characteristics. And this may account for some of the heterogeneity we've seen in studies to date. However, one thing to notice is that, interestingly, the incidence disease between these contact groups was not different. And based on this, the authors suggest we should continue to do contact screening in households of TB disease cases, regardless of the HIV status of the index case. So keeping with screening, these authors performed a study in Kenya among HIV-positive children under 12 years of age who had been hospitalized for any reason. And they performed an extensive TB symptom screen and then vigorous efforts to confirm TB diagnosis, including gastric lavage specimens sent for both culture and gene expert, and stool samples sent for gene expert. And this study showed that the WHO pediatric symptom screen had 100% sensitivity in this group, but only a 4% specificity, and 96% of the children screened positive on the symptom questionnaire and then had to undergo TB investigations for a low yield. So this group looked at a modified symptom screen where they looked at a number of options, but the best performing option was looking at TB exposure and weight loss. And those two symptoms together gave a 93% sensitivity and had a much lower lower number required to investigate out of the screen. Only 44% of children would have required TB screening in this case. They would have missed one case of TB with this modified pediatric symptom screen. In the Northwest Province in Cameroon, Tatahong and colleagues evaluated strategies for intensified case finding at health facilities, including a pilot use of gene expert tests for presumptive TB cases. And what I wanted to highlight from this abstract was that the laboratory staff in this program were trained and empowered to screen and test patients who presented to the lab to have other tests, non-TB related tests done, as well as patients self-presenting for TB testing. And this strategy showed a substantial added value to the yield of the intensified case finding. You can see an 11% positivity rate as opposed to a 3% among HIV-positive outpatients. Among HIV-positive patients and controls, Duncan Reid showed that macrophage migration habituatory factor allele expression, so MIF allele expression, was found to be low in patients with microbiologically confirmed TB when compared to the TB-free controls. So Reid and his colleague have suggested that the MIF allele may be a genetic marker for TB disease susceptibility. The next steps for this work would include assessing correlation of the MIF expression with disease severity, reactivation versus reinfection disease, and potentially a prospective cohort to look at the predictive value of this tool. And lastly, we cycle back around to IPT. Caro presented this abstract that showed that in he made the case that in low TB incidence settings, we need better predictors for who among our HIV-positive patients should be on IPT. And Caro used data from a German ClinServe HIV cohort over 10,000 patients and showed that following the initiation of combined ART, patients who had a CD4 count recovery of at least 400, or as this slide shows, a CD4-CD8 ratio of greater than 0.44, had a TB-free follow-up period for approximately 10 years on average. And so Caro and his group have proposed that patients who reach these protective thresholds at 3 months of treatment may not require IPT. And I'll hand over to the nurses and allied professions.
Good afternoon. My name is Lynette McElroy. I'm a nurse, obviously. I'm also a tuberculosis educator, and so I fit really well within this subsection. I have 3 presentations I want to highlight today, and as was said by Stella, I do apologize to those that we don't have time to include, but our co-chairs were absolutely adamant that I be short and sweet today. The short part is easy. I think I'm the shortest one on the panel. The sweet, we'll see what you think by the time I'm done. The first presentation I wanted to bring your attention to is by Gary and colleagues. These investigators recognized that one size might not fit all and offered a full complement of communication strategies to support patients taking TB treatment, which included encrypted email, fax, texting, landlines, cell phones, Skype, Viber, Google, chat, Facebook, and others. Though not an RCT, which hopefully will be done, they documented very high rates of TB treatment completion over 10 years at 84%. I've included a picture of the tool in case you're not familiar with that. The second presentation is by Zhao and colleagues. This was a short oral abstract that spoke to engagement of nurses. So engagement of nurses in tuberculosis education initiatives can have an important impact on global TB control, as demonstrated by the Training for Transformation program in China described in this abstract. Attendees of this training, implemented in China, reported impressive numbers of other healthcare workers trained, development of educational materials, and changes in practice, including increased psychosocial support and education for patients and family members. Since 2009, 204 TB nurses were trained. Those nurses went on to train over 4,000 others, and those others included other nurses, physicians, and allied health workers, nursing students, community staff, and community members. Pardon me. The third session is Alam and colleagues. This project described a very encouraging findings from Project Aisha's pilot implementation of a toll-free helpline that provided confidential access to standardized quality information on TB and TB treatment, as well as referral and linkages to TB diagnostic and treatment services within the caller's area. From the study we see, and it went from April of 2014 to February of this year, over 47,000 calls were made to the toll-free line. About 60% of those calls were linked to the local DMCs, which are designated microscopic centers. 30% of the calls were linked to RNTCP centers, and 10% of the people that called were actually calling for counseling or information that helped them stay on treatment. I think that was pretty short and pretty sweet. So,
Regarding tobacco control, the conference was a good mix of scientific and policy advocacy implementation work going on in different countries covering all aspects of Empower. A theme that emerged particularly across most of the sessions was that people and organizations working in tobacco control and other health agendas need to come together to form a united front to tackle the health issues in low and middle income countries. Now I'll present the highlights from the peer-reviewed sessions in the conference, and because there were so many for tobacco control, I've tried to compile them using the Empower, 6 components of the Empower. So, increasing the age of tobacco use initiation from 18 to 21 can potentially decrease tobacco use prevalence by 5 to 8% by 2025, mathematical models have shown. Raising age of purchase of tobacco at point of sale via educational and legislative measures could potentially discourage early initiation. These were findings from the GATS survey, India. In low and middle income countries, prevalence of exposure to secondhand smoke is significantly higher than rates of active smoking in pregnancy. In Bangladesh, particularly, among almost 95% of the children are found to be exposed to secondhand smoke, and these are findings from a survey. The major challenge in most of these countries is that smoke-free laws exist, but their enforcement is low. And some studies in China and India are particularly good, and lessons can be learned from them and scaled up. A study found that more than a quarter of the healthcare workers, especially physicians, believed that smoking does not impact TB treatments, which is quite concerning. And smoking cessation can reduce TB burden by 2 to 3% per year. This is from a study that used mathematical modeling in Indonesia to show this. An exemplary media campaign to prevent smoking in Moscow was found to be cost-effective and shows the potential to influence policymakers and governments. Hard-hitting mass media campaigns which depict graphical health warnings are more effective in changing behavior, it was found. Pictorial health warnings on cigarette packs are highly effective in thinking about quitting. This was another finding from India. Complementing paid social media with traditional media can also be an effective strategy to reach the target population. 85% pictorial warnings are implemented on locally produced cigarette packs in India, but the issue is that imported cigarettes, which come from other bordering countries, do not have any pictorial warnings. And there needs to be a similar kind of pictorial warning enforcements on other tobacco products as well. Article 5.3, most of these countries need to ensure that Article 5.3 gets enforced as well. Also, during this conference, various sessions highlighted the importance of regulating the advertising and promotion of e-cigarettes to the youth, and this is something emerging as a new issue. Finally, when price of cigarettes is increased by 10%, risk of tobacco use initiation drops by 14%. So taxation is a really important component of Empower. Loose cigarettes and small cigarettes drive the tobacco industry in many parts of India. And a study showed that pricing of these vary according to the socioeconomic status of the different jurisdictions, making it difficult to control. And this is how the tobacco industry works in countries like India, by changing pricing of cigarettes. Tax should be consistent for all tobacco products, regardless of their formulation, and it should be above the level of affordability. So this was my last slide. Thank you.
Good afternoon. Obviously, the TB section is highly diverse and are a huge number of abstracts presented. So again, apologies to those that are not mentioned, many of which were excellent. And I'm also going to go quite quickly through some highlights. So the first of these is from the MSF group, reporting on short course MDR treatment in Uzbekistan. They report data from 3 districts with the regimen, the shortened 9 to 12 month regimen you see there. And a key finding from this particular abstract was that the adjusted odds ratio of 2-month sputum culture conversion was over 2 for this regimen compared with a comparison group receiving traditional MDR treatment in districts where the programs and facilities were otherwise similar. This jibes with actually follow-up data, longer-term follow-up data presented by the same group at a symposium this afternoon, where again there seemed to be excellent longer-term data as you see here. Again, I'm not going to dwell on symposia in detail. Similarly, it jibes with the data shown from the Francophone African countries that many of you will have seen. Also, this morning at the CDC Union Late Breaker session, we had very exciting preliminary data from South Africa highlighting the potential impact of a 6-month treatment course for XDR or for patients unable to take standard MDR treatment for one reason or another. And you can see the drugs used on the left-hand side of your screen. And the inclusion criteria are listed here, so either XDR, MDR with non-responsive treatment, or MDR with treatment intolerance. And what you see here is, although the follow-up numbers have increased slightly, but they had 3 out of 12 patients who died early in treatment of essentially disseminated or progressive TB. On the other hand, of the 12 out of 15 who were successfully treated, they remained well and relapse-free 6 months later. So these are obviously very encouraging preliminary data. Also on the theme of MDR, of course there are many submissions on this, excellent submissions on this topic. We see from the PET study done in a number of countries, primarily those of the former Soviet Union, that in fact using serial cultures, that in fact resistance to fluoroquinolones and second-line injectables develops relatively rapidly, typically within the first 3 to 4 months of treatment. Also, in fact, from the same group, there's evidence, this is genotyping data where the investigators showed an association of a variety of PINK mutations with poorer MDR treatment outcomes, summarized here. So you can see, for example, that death and treatment failures were substantially more common, notably in individuals who had insertion or deletion type mutations. This is a very busy slide, but the bottom line here, this is taken from an e-poster by Millard and colleagues. The bottom line here is that they investigated using a combination of meta-analysis and Monte Carlo simulation modeling. They investigated the possibility of using lower doses of linezolid, and in fact, the available data used in this manner suggests that it would be possible potentially to substantially lower the dose of linezolid, perhaps to 300 milligrams daily, keeping good pharmacokinetic parameters, but in fact reducing toxicity. This was turning now to latent tuberculosis. This is a study by Ruwald and colleagues looking at essentially a skin test using the reagents found in interferon gamma release assays, or the antigens, I should say. So skin test using ESAT6 and CFP10 as compared with the tuberculin skin test and also the quantiferon test. Oops. Sorry about that. Not sure what happened there.
It's showing behind you.
Oh, it's showing. Okay, sorry, it's just not showing on our screens. So in fact, this study showed that in a number of contacts and non-contacts, in this particular case in Spain, although there were other data shown, this test performed with what appeared to be, or suggested to perform with a high degree of sensitivity and specificity with a clear gradient according to the degree of contact. remaining on LTBI, but turning now to modeling, this is an important study estimating the global burden of latent tuberculosis infection, where in fact, based on a number of available epidemiologic data and surveys, it was estimated that in fact, just under a quarter of the world's population is likely to carry latent TB or to harbor latent TB infection, which translates into 1.7 billion individuals total and 97 million children with confidence intervals you can see there. And obviously, if you're interested in the detailed methods, please refer to their presentation. And this summarizes more country-level estimates of the prevalence of latent TB infection. A very provocative study actually from Taiwan made the suggestion that in fact, even with fairly concerted action to reduce alcohol use, to stabilize the prevalence of diabetes and eliminate undernutrition in that country, that in fact the total impact on TB incidence was likely to be relatively modest. And obviously this requires further attention, but as I say, it's quite a provocative study. The authors assumed, in fact, that smoking reduction trends, which you see in the left upper corner, would continue, and despite this, again, only a 20% reduction in TB incidence in that country was projected with these measures. This was, there was quite a bit of attention given to mobile health applications, as we've already seen. This is a study from South Africa, where in fact both community-based and health facility-based screening and diagnosis programs were supported by an mHealth application, which also included a video showing appropriate methods for sputum collection. There were also financial incentives for screening and case finding in both the community and the health facility settings. And in fact, one of the interesting findings was that in the facility, about 59% of persons with suspected TB provided sputum samples, whereas in the corresponding community sample, it was as high as 95%. There was also a lot of attention at this conference to the stigma associated with TB. We had an excellent presentation this morning on many elements of stigma and disease perceptions in a Brazilian indigenous community. I would strongly suggest you look at the slides for more information, but among other things, the investigators looked at different dimensions or sorts of stigma voiced by individuals in this community. Finally, and importantly, this conference emphasized the continuing contribution of war, displacement, and other catastrophes on health and on TB. We had a symposium on effects of the civil war in Syria, as well as presentations, very impressive presentations from war-torn areas such as Afghanistan, and I would like to salute the presenters and the organizers for making this possible. Thank you.
Thank you. My name is Alejandro Pereira. I'm a veterinarian, and I'm the program secretary of the zoonotic TB subsection. And the topic that I wanted to present is about abstract that we received and were presented as posters regarding the non-tuberculosis mycobacteria. And you may say that these are not zoonotic tuberculosis. However, we supported the presentation of these posters because as the challenges we are facing in regards of zoonotic TB, mainly on Mycobacterium bovis, these non-tuberculosis mycobacteria challenges are very similar, are in some way not considered to be important. However, in these posters, in these abstracts that we received, which were 9, we found a lot of similar situations, similar challenges and scenarios that we are facing in our zoonotic TB and our project and push for the awareness and penetration in the public health community regarding MOBIs. So we went through 9 abstracts that were from different countries: India, Japan, Turkey, Pakistan, Brazil, Ghana, Namibia, and Mali, that are listed here. You can see critical significance of non-tuberculosis mycobacteria isolated in a mycobacteriology laboratory in India. Another that was by Talaki, nationwide laboratory survey in of uncommon mycobacteria isolated in Japan. Pulmonary non-tuberculosis mycobacterial infections, study on 372 cases. And all of these were very similar in situations, having a good number of patients, and an important section of those samples were found with non-tuberculosis mycobacteria having clinical and pathological signs in patients. Also, the prevalence of non-tuberculosis mycobacteria among the presumptive TB cases in Namibia by RUSWA, identification and drug susceptibility profiling of non-TB mycobacteria species from sputum smear positive pulmonary case in Ghana, diagnosis of not tuberculosis mycobacteria in immunocompetent chronic lymphadenitis cases, an emerging entity. Molecular diagnosis of non-tuberculosis mycobacteria at the Center of Infectiology by Taore. Spectrum of susceptibility pattern of non-tuberculosis mycobacterial infection in Pakistan, and the distribution of pulmonary non-tuberculosis mycobacteria cases in the information system for special tuberculosis treatment in Brazil. All of these were very similar in the approach of trying to identify non-tuberculous mycobacteria in patients in which they tried to see if those were contamination at the laboratory or at the hospitals, or they were really co-infecting the patients in some cases, and in some others, there was no mycobacteria for TB complex, only the presence of these non-tuberculosis mycobacteria. So, as I said before, these type of studies and this issue is not well considered as an important in general. So the following conclusions were taken from these different studies. Results highlight the importance of speciation of mycobacteria, not only for appropriate diagnosis, but also to rule out laboratory contamination. The major not tuberculosis mycobacteria isolated were Mycobacterium avium in a high percentage, Mycobacterium gordonii, and Mycobacterium abscessus, and abscessus complex. Another conclusion was identifying non-tuberculosis mycobacteria strains ensures correct treatment approaches. In one of the studies, the HIV positivity was highly associated with non-tuberculosis mycobacteria, 52% versus to association with mycobacteria of the complex, tuberculosis complex, 5.8%, an important data. Another conclusion was in one of the studies, 43 non-tuberculosis mycobacteria identified in one study were resistant to isoniazid. 16 were resistant to the 3 drugs, streptomycin, isoniazid, and rifamycin, and 2 are resistant to isoniazid and rifamycin, and 3 resistant to streptomycin and isoniazid. Also, the mycobacterial abscesses were resistant to all 3 drugs, whereas the M. avium were resistant to isoniazid and rifamycin. So considering the prevalence and the observed high resistance, it is important to consider non-tuberculosis mycobacteria in the global effort to control TB, especially if we are saying that We want to have zero TB 2035. So this is something to consider for the health professionals. Another conclusion, and the last one, was not tuberculosis mycobacteria may play an important role in human diseases and should be considered as cause of morbidity and mortality in resource-limited settings, since isolation of the organism does not necessarily indicate clinical infection. Communication between biologists and clinicians is important to coordinate the diagnosis. And I think this is the last one. That's all I have.
So with that, we've concluded the rapporteur session. I want to thank, first of all of the abstract reviewers. There were hundreds of people that contributed to this, as well as the chairs that assisted, but most notably our wonderful panel, the CCSA dedicated individuals sitting here. And we're going to transition into the closing ceremony now. So while they get a chance to find their seats.